Vascular territories. Anterior cerebral artery supplies the medial frontal lobe, highlighted here in yellow. So ACA infarctions cause contralateral leg weakness, contralateral lower extremity sensory loss, and anterograde amnesia by damaging the cingulate cortex, which is part of the memory circuit. Just picture in your mind a patient who appears more forgetful, withdrawn, slow to respond, and dragging a weak leg when walking. Middle cerebral artery territories in red are by far the largest in the brain. MCA territory infarction may include contralateral hemiparesis from damage to the primary motor cortex and descending motor pathways, contralateral facial paresis, again from damage to corticobulbar fibers, contralateral gaze paresis from damage to the frontal eye fields. If you infarct the left frontal lobe, you would not be able to look to the right, causing a right gaze paresis or left gaze deviation. Aphasia, with damage to dominant frontal and temporal lobes where expressive and receptive language pathways reside. Contralateral hemisensory deficits, with damage to the primary sensory cortex and the parietal lobe and the ascending sensory pathways. Field cut, or homonymous hemianopia, with damage to both temporal and parietal optic radiations. Neglect, with damage to the non-dominant parietal lobe. A patient with MCA occlusion does not necessarily have to have all these deficits. A quick note, the head of caudate is supplied by a tiny branch of the ACA called the recurrent artery of Hübner. Well, if you see a comma-shaped infarct like this, then both MCA and ACA territories were likely affected, and transiently occludes both ACA and MCA. Posterior cerebral artery supplies the inferior medial temporal lobe and the occipital lobe. PCA supplies the thalamus. Thalami receive and send projections to all the lobes and then some. So PCA strokes can sometimes mimic MCA strokes. Patients get contralateral hemisensory loss from damage to sensory nuclei in the posterior thalamus, contralateral hemianopia from occipital lobe damage, rarely neglect with non-dominant thalamic damage, transcortical aphasia with dominant thalamic damage. I wasn't kidding about the thalamus talking to everything. Transcortical aphasias are less severe than the classical Broca's and Wernicke's with intact repetition, and global cognitive issues like behavioral abnormalities, confusion, and even memory difficulties. To make things even more difficult, PCA is the terminal branch of the basilar, so it supplies the midbrain. Midbrain is brainstem. Overlaid in blue are some sample strokes of the midbrain. Damaging the motor fibers in the cerebral peduncle causes contralateral hemiparesis. Contralateral ataxia can result from damage to the red nucleus, which is part of the cerebellar pathway. And damaged oculomotor nucleus causes ipsilateral CN3 palsy, ptosis, medial rectus weakness, superior rectus weakness, that sort of thing. The superior cerebellar artery is easy. It supplies the anterior superior cerebellum. So infarctions here cause ipsilateral ataxia. The cerebellar fibers are damaged after double crossing. The basilar artery supplies mostly the pons and the anterior medulla. Damaging the anterior medial pons causes contralateral hemiparesis and facial paresis, intranuclear ophthalmoplegia, caused by interrupting the medial longitudinal fasciculus, the connection between pontine paramedian reticular formation, horizontal gaze center, and the oculomotor nucleus in the midbrain. Spinothalamic tract damage causes contralateral hemisensory loss. Patients with damaged lateral pons and cerebellar peduncles will have contralateral ataxia, kind of like the contralateral ataxia of the red nucleus damage in the midbrain, not at all like the ipsilateral ataxia of the cerebellar strokes. Pontine paramedian reticular formation damage will cause gaze weakness. And finally, when 5th and 7th cranial nerve nuclei are damaged in the lateral pons, the patient will have low motor neuron type facial paresis, the whole face involving the forehead and eye closure, and ipsilateral facial numbness.